welcome to the deep dive. Imagine trying to perform, like, delicate surgery on a moving train.
Oh, yeah. A nightmare.
Right. The floor is constantly vibrating, the lighting flickers on and off, and every time you reach for an instrument, the train just lurches around a sharp bend.
That level of sheer unpredictable chaos is basically what doctors deal with when they're trying to diagnose and treat conditions in women's reproductive health.
Exactly, because the environment inside the reproductive system is, well, it's never static. It's this biological landscape in constant flux.
Yeah, it's driven by a hormonal clock that, honestly, for many people, just refuses to keep regular time.
Which brings us to our mission for today's deep dive. We are opening up a massive stack of sources today. We've got official clinical guidelines from the NHS, medical protocols for minor gynecological procedures.
And we also have those really dense clinical studies on therapies like vaginal lasers, plus some strict FDA safety advisories.
Yeah, it's a lot of material. But pulling all these documents together reveals this totally hidden clinical reality. We are exploring a highly practical but surprisingly overlooked question. Can irregular periods affect treatment timing?
And for anyone listening who actually experiences erratic or heavy cycles, you already know the daily mental calculus, right? Just trying to leave the house.
Oh, absolutely. You're mapping out bathrooms, you're wearing specific clothes.
Right. But looking at these medical protocols, this unpredictability it's way more than a personal inconvenience. The medical field itself is forced to work around the body's erratic schedule.
And when that schedule breaks down, it creates this cascade of clinical hurdles that actually dictate when or even if you can get treatment.
Yeah, it really does. We have to start with diagnosis because before any treatment happens, a clinician needs a clear picture of what's going wrong.
Right, but how do you time a diagnostic test when the cycle itself is like a completely moving target?
Exactly. Let's look at the clinical guidelines for hormone testing. So if a patient is dealing with infertility or irregular cycles, a primary step is testing circulating progesterone levels.
Just to confirm if ovulation's even happening at all, right?
Yes. The biological mechanism is that after an egg is released, the empty follicle, which is called the corpus luteum, starts pumping out progesterone.
Okay, to prepare the uterus lining for a potential pregnancy.
You got it. But to capture that hormonal peak, the protocol strictly mandates that progesterone has to be measured exactly 7 days before the start of the woman's next cycle.
Wait, 7 days before the start of the next cycle?
Yep. So in a textbook 28-day cycle, you draw blood on day 21. In a 35-day cycle, you test on day 28.
I am looking at that rule, and my brain is I'm trying to wrap my head around the logic here. If a patient is sitting in a doctor's office with totally unpredictable cycles, they have literally no idea when their next period is going to arrive.
None. Zero idea.
So asking someone to schedule a blood test exactly 7 days before an event that might happen, I don't know, next week, next month, or in 3 months, that feels like asking them to predict the future.
It does. And it creates a massive diagnostic bottleneck. The medical system here is relying on retrospective data for a prospective action because the patient obviously cannot predict the future. Doctors are forced into this frustrating trial and error approach.
What do? Just guess.
Basically, yeah. They estimate a date based on whatever historical data the patient has. They order the blood draw, and then everyone just waits.
Oh, wow.
And the biological reality is that if the period doesn't arrive exactly 7 days after that needle goes into the arm, the progesterone levels in that vial are clinically meaningless.
Because the hormonal window was just entirely missed.
Exactly. The data is useless for diagnosing ovulatory function, and the patient just has to start the whole guessing game over again the next month.
That sounds incredibly frustrating. So the chemical markers are practically invisible without perfect timing. But what about physical imaging? Like, let's pivot to transvaginal ultrasounds.
Oh, this is fascinating. You would think taking a picture of an internal organ would be straightforward.
Yeah, you just take a picture.
Right, but the sources emphasize that these scans also have incredibly tiny, strict diagnostic windows. They strongly advise doing them immediately post-menstrually.
Just right after the bleeding stops.
Yes, because sound waves need the right physical medium to bounce off of to create a clear image. Throughout the month, hormones cause the endometrium, the lining of the uterus, to grow significantly thicker.
And it gets more vascular, right? Full of blood vessels.
Exactly. So if you do an ultrasound right before a period, the sound waves hit this thick, dense, fluid-filled tissue, and they just scatter.
Okay, I love the analogy we were talking about earlier for this. It's like trying to find a coin dropped on the floor.
Yes, the carpet analogy.
Right. If you search for it just before a period, it's like looking for that coin in a thick 1970s shag carpet.
Exactly. The dense lining just swallows the shape of whatever is hiding in there.
But if you do the ultrasound right after the bleeding stops, that carpet has been completely stripped away. The functional layer is shed, and the lining is at its absolute thinnest.
So you are suddenly looking at a bare hardwood floor.
Right. The sound waves bounce cleanly. And that coin, which, in this context might be a polyp or a fibroid or a cyst, it just stands out with stark, high contrast clarity.
It really is a perfect structural metaphor, and if a patient is constantly bleeding or their cycle is so erratic they can never confidently schedule an appointment during that hardwood floor window,
Then identifying the root cause is severely delayed.
exactly. The physical structure of the body is literally hiding the evidence.
Okay, so if diagnosis is sidelined by the cycle's timing, what happens when we try to physically put something in there? Let's move to mechanical interventions.
Like inserting an intrauterine system.
Right, commonly known as an IUS or a hormonal coil. The clinical protocols provided in these sources outline very rigid rules for this.
They really do. Technically, a doctor can insert an IUS at any time as long as they're absolutely certain the patient isn't pregnant.
But the clinics strongly prefer, and in many cases actually mandate, that the insertion happens within a specific window, right? Days 5 to 14 of the menstrual cycle.
Yep, days 5 to 14.
I'm looking at this window and trying to make sense of the anatomy. Is it just because they want to ensure the period is over, or is something structural actually happening to the uterus then?
It is entirely structural, and it's driven by that shift in hormones. During days 5 to 14, the body is in the follicular phase, and estrogen levels are steadily rising.
Okay, and what does the estrogen do?
This rise in estrogen actually alters the collagen fibers in the cervix, the narrow neck of the womb that the device has to pass through.
Oh, wow, so it changes the actual tissue.
Yes. The tissue physically softens, and the cervical opening, the os, naturally dilates slightly.
So a softer, slightly open cervix just naturally reduces the physical resistance when the doctor guides the insertion tube in.
Exactly. It makes the procedure significantly more comfortable for the patient, and it drastically increases the success rate of placing the device flush at the top of the uterus.
Okay, that makes total sense.
Yeah.
But I noticed a really strict rule in these clinical protocols that just stops this entire process in its tracks. If a patient is bleeding heavily on the day of their appointment, they have to reschedule.
Yeah, that is a hard line for a lot of clinics.
Wait, so let me get this straight. The medical system's answer to a woman who is bleeding too much is to tell her to come back when she's not bleeding.
I know.
But that is the exact reason she needs the hormonal coil in the first place. How does that make any clinical sense? It sounds like this agonizing catch-22 where the symptom prevents the cure.
The frustration for patients trapped in that rescheduling loop is immense. It really is. But the clinical caution is rooted in the actual physical risks of the procedure.
Okay, what are the risks?
Well, inserting an IUS is basically a blind procedure. It's guided by anatomical feel. The clinician needs absolute clarity, and heavy active bleeding totally obscures the visual field of the cervix.
Oh, right. They literally can't see what they're doing.
Exactly. And more importantly, when the uterus is actively shedding its lining, the tissue is highly friable.
Friable, meaning it tears easily.
Yes, it tears easily and the area is inflamed. The sources note there is a 1 in 1,000 chance of the device perforating the muscular wall of the womb during insertion.
Oh, wow. A 1 in 1,000 chance of puncturing the uterus. Okay,
Yeah.
that suddenly makes that delay very understandable.
Yeah, if the anatomical conditions aren't optimal, that risk of perforation goes up, and infection control is another major factor.
Sure, because you're introducing a foreign object through an open cervix.
Exactly. Doing that while heavy bleeding is washing bacteria downward is a clinical risk most doctors simply will not take.
Okay, but what actually happens to the patient who keeps getting canceled? They can't just be left to bleed indefinitely.
Right. No, they aren't. When the cycle refuses to provide a safe anatomical window, pharmacology has to step in. Clinicians will prescribe medications like tranexamic acid.
And that's not hormonal, right?
Right, it doesn't contain hormones. It works by slowing the breakdown of blood clots in the uterus, which significantly reduces the volume of bleeding.
Okay, what else can they do?
Alternatively, they might use high-dose oral progestogens to medically force the lining to stabilize and just stop shedding.
Got it. So the goal is to chemically manufacture a pause in the bleeding, just long enough to get that patient safely into the procedure room and get the device inserted.
Exactly. Buy enough time to get the coil in.
So if physical devices like an IUS are sidelined by heavy bleeding and fragile tissue, you'd think the medical field would turn to something energy-based, right? Something that doesn't rely on physical placement.
Like lasers.
Exactly, lasers. I am looking at the clinical studies on fractional CO2 vaginal laser treatments,
Yeah, so these energy-based devices are primarily used to treat genitourinary syndrome of menopause, or GSM.
which involves severe vaginal atrophy, dryness, and pain, usually as estrogen levels just plummet.
Right. And a lot of patients experiencing these symptoms are in perimenopause, meaning they still have unpredictable overlapping menstrual cycles.
So how does the laser actually work on the tissue?
The CO2 laser works by creating microscopic, precisely spaced thermal wounds deep in the vaginal wall.
Right.
The body recognizes these tiny thermal injuries and sends fibroblasts rushing to the area to produce fresh collagen and elastin.
So over time, this biological healing response restructures and thickens the vaginal tissue,
Right.
restoring elasticity and moisture.
Exactly. It's a controlled microscopic injury to trigger a massive healing response.
That makes total sense. But looking at these clinical guidelines, even light gets derailed by the cycle. The guidance heavily advises against scheduling a laser session if the patient is menstruating or experiencing irregular bleeding.
Yeah, the physics of laser therapy actually demands a clear line of sight. Lasers operate on the principle of targeting specific chromophores.
Chromophores, what are those?
They're basically the molecules that absorb a particular wavelength of light energy. So in fractional CO2 lasers, the target chromophore is the water inside the vaginal tissue.
Okay. But if there is active bleeding in the vaginal canal,
The hemoglobin in the blood physically blocks the light.
it's like trying to cook a pizza in an oven, but there's a giant block of ice sitting on the rack above it.
Yes. All the oven's heat goes into melting the ice, and the pizza just stays totally raw.
So the laser's energy gets entirely absorbed by the blood pooling in the canal, vaporizing the blood instead of penetrating the vaginal wall.
Exactly. Leaving the actual tissue completely untreated, the light literally never reaches its target.
That is wild.
And beyond the physics failing, the biology of a menstruating patient makes the procedure genuinely unsafe.
Because of the micro wounds.
Yes. We discussed how the laser creates thousands of microscopic thermal wounds. If you introduce open microabrasions into an environment filled with menstrual blood and cellular debris, you are creating an ideal breeding ground for bacterial infection.
Ugh, that sounds incredibly risky.
Plus, the entire pelvic region is already vascularly engorged, inflamed, and cramping during a heavy bleed, so the pain and swelling from the laser just amplify the patient's discomfort dramatically.
Which leads to a crucial warning highlighted in the medical protocols regarding what happens after the patient goes home. The sources flag a very specific danger regarding post-treatment bleeding.
This is so important. If a woman experiences sudden bleeding or menstruation issues following a laser session, the medical consensus is that the laser did not cause the irregular period.
Right, the danger lies entirely in the patient's assumption.
Exactly. It is super common to experience minor light spotting for a day or two after a laser treatment as those micro wounds heal.
But because so many of these patients already suffer from erratic cycles, their instinct is probably just to dismiss a sudden gush of blood or pelvic pain as, oh, it's just my period showing up at a weird time again.
Yes, and the clinical warning is stark. Do not confuse a severe post-procedure complication with an irregular cycle.
Right. If a patient experiences severe pelvic pain, foul-smelling discharge, a fever, or heavy bleeding that soaks a pad in an hour,
They are likely experiencing a massive infection or a severe tissue complication. Assuming it's just the menstrual cycle acting up can lead a patient to ignore a literally life-threatening medical event that requires emergency evaluation.
wow. Throughout this whole deep dive, we've seen the menstrual cycle dictating the schedule at every single turn.
Oh, absolutely.
It forces doctors to dodge the bleeding to capture hormones, delay mechanical insertions because the cervix isn't ready, and abandon laser optics because blood absorbs the light. But what if the treatment is designed to destroy the source of the bleeding itself?
Definitive interventions.
Yes, we need to talk about endometrial ablation. For patients who are changing pads every hour, bleeding for weeks on end, or suffering from clinical anemia due to massive blood loss, ablation is offered as a surgical reset button.
Right. So instead of trying to time things around the growth of the lining or using pills to suppress it, an ablation procedure actively destroys the architecture of the uterus.
How did that actually work anatomically?
Well, the endometrium has two layers, the basal layer at the bottom and the functional layer on top. The functional layer is the part that thickens and sheds every month.
Okay, the shag carpet.
Exactly. So during an ablation, a surgeon inserts a device into the uterine cavity that uses extreme heat, freezing temperatures, or even a radio frequency mesh.
And that energy just completely ablates, meaning it burns away or freezes that entire functional layer down to the muscle.
Yes. By entirely destroying that specific tissue bed, the body physically cannot respond to hormone fluctuations anymore. The lining simply cannot regrow.
And looking at the clinical outcomes, the success rates are staggering. Between 85 to 90% of patients report successful control of abnormal uterine bleeding.
It's life-changing for many. Many stop bleeding entirely forever, while others drop down to very light, manageable spotting.
Right, it is this wildly effective day surgery alternative to a full hysterectomy, saving the patient from having their entire uterus surgically removed and cutting recovery time down from weeks to just days.
And this is but looking at the FDA advisories and the patient selection criteria, the limitations on who can actually get this miracle procedure are incredibly rigid.
Right, because altering the fundamental structure of the uterus carries severe long-term consequences.
Yes. First, ablation is strictly for premenopausal women who are absolutely certain they do not want future pregnancies.
The FDA source is very firm on this. Pregnancies following ablation aren't just unlikely, they are catastrophic for both the mother and the fetus.
Completely catastrophic.
I'm trying to visualize the anatomy post-ablation. Is it because the burned tissue can't stretch, or is it a problem with the placenta?
It is a placental crisis.
Yeah.
Because the functional lining has been destroyed and replaced by dense scar tissue, the uterus is extremely hostile to implantation.
Okay, but what if an embryo does manage to attach?
If it does, the placenta has no soft, nutrient-rich tissue to anchor into, so instead it aggressively digs directly into the uterine muscle wall seeking a blood supply.
Oh, wow.
This is a life-threatening condition called placenta accreta. As the pregnancy progresses, the scarred uterus cannot expand properly, which leads to severe fetal complications, late-term miscarriage, and massive, uncontrollable maternal hemorrhage.
That is terrifying. So patients who undergo ablation basically must commit to using highly reliable contraception continuously until they safely reach menopause.
Absolutely non-negotiable. And beyond the pregnancy ban, the physical shape of the patient's uterus holds ultimate veto power over the surgeon's tools.
Right, because of things like fibroids.
Exactly. The ablation devices like a thermal balloon or a radiofrequency mesh, they're designed to expand and make flush, uniform contact with the inside walls of a normally shaped uterine cavity.
Okay, so if a patient has large fibroids, specifically anything over 3 centimeters, those benign tumors warp and distort the shape of the cavity.
Right, and the device just cannot reach around the fibroid, leaving pockets of endometrial tissue untouched and able to bleed.
Making the whole procedure pointless.
Pretty much. Furthermore, if a patient has an IUD, it must obviously be removed before you can deploy a heating device inside the same space.
Obviously.
Ah.
There is one more caveat in the guidelines that requires defining a specific medical term. The procedure cannot be performed if there is any suspicion of endometrial hyperplasia.
Yes, that's a critical one.
What exactly is the lining doing in that scenario?
So endometrial hyperplasia is a condition where the lining doesn't just grow thick, the cellular structure grows wildly out of control. It's usually due to an overabundance of estrogen without enough balancing progesterone.
And that's dangerous.
Highly dangerous because it can be a direct precursor to endometrial cancer. Before any surgeon will perform an ablation, they mandate a tissue biopsy to ensure hyperplasia isn't present.
Because you can't just burn it away.
No, you cannot simply burn away hyperplastic tissue. If you do, you risk burying microscopic precancerous cells deep underneath a thick layer of dense scar tissue.
Oh, so those cells could later mutate into cancer, completely hidden from future diagnostic ultrasounds or biopsies.
Exactly. Hidden until the disease has advanced to a late, completely untreatable stage.
Wow. It really emphasizes that while modern medicine has engineered these incredible high-tech interventions, the physical, biological landscape of the human body still entirely dictates the rules of engagement.
Always.
Let's take a step back and summarize the journey we've just been on through these medical sources. We've learned today that irregular periods aren't just a frustrating daily personal issue. They are a massive logistical and physical hurdle in the practice of clinical medicine.
Yeah, the menstrual cycle literally shapeshifts the entire internal environment.
It alters the thickness of the lining, turning the uterus from a shaggy carpet that hides tumors into a clear hardwood floor. It changes the physical softness and dilation of the cervix, determining whether surgical tools can even safely enter.
And the presence of blood dictates the optical visibility for high-tech lasers, absorbing energy before it can ever reach the tissue.
Right. And, understanding the mechanics behind these clinical rules is deeply empowering.
It really is. Knowing exactly why a clinic insists you come in on day 8 of your cycle to check your progesterone, or why you are repeatedly rescheduled for a coil insertion when you are bleeding heavily, it strips away the mystery.
You aren't just being difficult when you ask your doctor questions about timing. You're actively participating in the science of your own care.
Exactly. It allows you to advocate for yourself, ensuring you aren't subjected to painful procedures during the wrong biological window, and ensuring the diagnostic tests you pay for actually yield usable data.
Which brings me to a final thought for you to mull over. Think about the immense amount of hidden, silent data your body is constantly producing every single day.
The shifting hormone levels, the structural changes to the tissue, the presence or absence of a bleed.
Given how crucially doctors and multi-million-dollar medical systems rely on the precise timing of your cycle to safely perform their interventions, could the simple everyday act of tracking your own menstrual symptoms on a calendar or an app actually be the most powerful foundational piece of medical technology you own?
I mean, we constantly look to surgical ablations, fractional lasers, and complex hormonal blood panels as the absolute height of medical technology. But none of those interventions work safely or effectively without the simple daily biological data that only the patient can provide.
Your tracking unlocks their potential. Keep tracking the data, keep challenging the timing of your appointments, and never underestimate the immense clinical power of knowing your body's own rhythm.